Welcome to the webinar. This is David Hall. I'm the Chief Marketing Officer at Hall Benefits Law, and I would like to ask your patience as we give folks about another minute to go ahead and get logged in. We've got quite a few people signed up, and we want to make sure that everybody has the benefit of the full presentation. Again, thank you for your patience, and we'll get started in approximately 1 minute. Okay, let's jump right in, folks. My name is David Hall. Welcome to this webinar, ICHRA MEC. What the heck? We are co-presenting with Lockton today, and we are excited to do so. Let's go ahead and look at our table of contents for today's presentation. I'll be doing some brief introductions. Lisa with Lockton will do a level set of today's topics. And then we have two other folks from Lockton who you'll meet shortly, as well as lead ERISA counsel Eric Schillinger from Hall Benefits Law presenting on ICHRA and MEC plans. And then we will have an opportunity at the end for questions. I would encourage you, if you do have a question, to submit your question via the questions section in your control panel. Type those in. I will be monitoring those during the presentation and getting those questions into the hands of the presenters, so that we can get you a good answer. If we're unable to answer your question for any reason on today's webinar, we promise we'll follow up directly with you, so don't be afraid to submit a question. If you'd like us to follow up directly with you, just indicate that when you submit your question. We'll be sure to hold that out and contact you directly post-presentation. So without further ado, we're gonna get started. Today's presenters from Lockton are Lisa Metcalf, James Billings, and Kent Horseman. And from Hall Benefits Law, myself, I'm the Chief Marketing Officer, and fortunately for all of you, I'm about to jump off and you won't hear much from me again. More importantly, lead ERISA counsel Eric Schillinger has some important information to share in conjunction with Lockton. So that being said, I am going to turn this over to Lisa, and she's going to tell us all a little bit about Lockton.
Great, thanks, David. So Lockton is the largest privately held insurance consulting firm, both globally and in the US. We work with mid-market to large employers that typically manage complex businesses and often have very lean teams. So we find that our clients generally need a partner that can roll up their sleeves and serve as truly an extension to their teams. As a privately held firm, our focus is not on our investors or analysts, but rather we're able to have a really critical focus on those that we serve. So we do invest heavily in our people, and I think that's truly a key differentiator for us. Our account teams handle a maximum of 8 to 12 clients, so it really allows us to get to know our clients and understand their businesses on an intimate level. We really strive to understand the how and why behind our clients' businesses so that we can help see the unforeseen that they may not understand. A lot of times we find that our clients just don't know what they don't know, and it allows us to deliver efficient, cutting-edge solutions to them. So while today's focus will ultimately fall within our benefits practice, we do also consult on total rewards, compensation, risk, retirement, and mergers and acquisitions, amongst a variety of other things. And David, I'll turn it back to you so you can speak a little bit about Hall.
Thank you so much. Well, we are HBL. We're a boutique law firm. We specialize in ERISA and employment law. For the last 3 years, 2018, 19, and 20, we've been recognized as the fastest growing ERISA law firm in the United States. Our mission is to stand at the forefront of ERISA and employment law compliance by providing the highest quality guidance and responsiveness in the country. And in adding an employment law practice last year, we did so basically to help fulfill our mission of addressing all compliance liabilities. So those two practices work in tandem to do so, and we have a proactive and holistic approach to how we handle matters, client matters. We do have a group of core ERISA services that you can see there, in addition to our core employment law services. There's more that we do than what we could put on one slide. So if you have any questions about our capabilities, I would encourage you to visit our website, www.hallbenefitslaw.com. So Lisa, I'm gonna turn it back over to you for a level set, and then we'll get down and dirty.
Sounds good. All right, so if you want to move to the next slide, really I just wanted to make a point that today's focus is really on two potential solutions that may or may not be a fit, pending your financials, your workforce, how you leverage your benefits for recruitment, retention, really a myriad of things. As we work with our clients, strategic planning serves as really a foundational jumping point. Planning can start at any point along this pathway, but really consists of numerous parts. So ultimately, we want to really learn about our clients, fully understand their businesses, even the parts that don't necessarily relate to their benefits programs, understand their operational priorities, their values and beliefs, where they've been and where they want to go. And then in turn, we also take part by educating our clients. So maybe that's reviewing utilization and financial performance, helping them understand cost drivers, market trends, changes in the regulatory environment, and really the insurance marketplace. So at that point, once those two things are done, then we can really sit and work together with our clients to help them put together a plan, not just for the year, but also a 3 to 5 year strategic roadmap to help them to ensure that short-term decisions all track towards a common goal. David, if you want to go to the next slide. So while we do create that roadmap, at times changes obviously can occur, causing a need to pivot. This year definitely is one of those years. So whether it's internal or external influences, such as maybe business needs, goals, acquisitions, or perhaps our socioeconomic or legal environment, obviously 2020 and the start to 21 have presented some fairly unique circumstances. And as such, I'm sure many of you think about your last year in review, really almost to the date. You've probably had a lot of changes occur in your businesses and have had to really quickly adapt to new normals. So this just goes to say that roadmaps and strategic plans, while they're great to have, they're fluid, and we do revisit those numerous times throughout the year to ensure tasks to completion are on track, but also to make sure that our previously outlined priorities still align amongst any changes that might be occurring in any of those areas. Next slide. The other thing that I just want to note is that for today's discussion, ICHRAs and MECs may or may not be viable solutions for your organization. So I'm sure for many of you that manage your company's insurance, whether you're self-funded or fully insured, you're seeing costs rise on an annual basis if you were to do nothing. So historically, we've seen an annual trend of 5 to 7%, and oftentimes we are tasked with mitigating that trend line for our clients. Depending on their goals and needs, we even need to reduce costs sometimes to allow them to allocate funds to other areas within their total rewards package or maybe within their business. So we have a lot of different traditional inflators that you guys have probably seen, such as aging population, employees having difficulty navigating the system, rising labor costs, but there's several external inflators as well. So a good example of that, the removal of policy limits with the Affordable Care Act has really driven high cost claims. In the past, if you had $1 million hemophiliac, for example, that limited that liability. But with the untapping of limits, that's really driven high cost claims, especially when we couple that with new technology and clinical advances, both on the medical and on the pharmacy side. With COVID, we're seeing a lot of new inflators coming to the forefront with the pandemic, and that's especially highlighted several areas of opportunity from both a communication and engagement perspective, but also in how we need to help our clients manage their financials. Next slide. So the reality is today that our world has gotten a lot more complex. For those of you that have been around for a while, really managing a benefit program in years past, it's evolved quite a bit. It used to be really just simply managing an administrator, your network, and your costs. And now there's a million different pieces and parts that require coordination. And realistically, there's a number of different ways to accomplish your goals, lots of different avenues, just depending upon your needs and really your core philosophies about your benefits, your people, and your business. Next slide. And so that brings us really ultimately to today's discussion. We're really seeing a lot of emerging trends, some older ones that have gained more traction amongst our current environment, and others that are brand new in reaction to many of the events of 2020. So many of the recent conversations that we are having with employers align around how to engage with employees, how to continue to manage within the environment of COVID, and ultimately cost mitigation. There are several hundred ways to do this within a more traditional environment through network pricing strategies, plan design, transparency, advocacy, the list goes on. But as legislation has allowed and expanded the options available, we've seen really a renewed interest in exploring alternates, two of which are the foundation again for today's discussion. Next slide. And so we can move forward one more. And really this is just the strategies that we're looking at for today. So again, we mentioned ICHRA. So really a type of individual coverage health reimbursement account. It really consists of an employer-funded monthly allowance, and it provides reimbursement for both qualified medical expenses, but also health insurance premiums. So it's a little bit different than what you guys all are familiar with as a traditional HRA. But employees must be enrolled in an individual health insurance plan, and they can't receive premium tax credits for that. And we'll get into this in a lot more detail in a bit here. But then the second approach that we'll be discussing today is minimum essential coverage plans, which is really a limited plan that still meets some of the ACA requirements for having insurance coverage. And it often includes some limited copay coverage, some prescription drug coverage, and then there's an indemnity component that will help your employees for hospitalization or major services. If you wanted something beyond that indemnity component, it can be paired with a low-cost major medical coverage to still provide catastrophic coverage or offer it as a standalone. I think once Kent gets into some of the plan designs, that'll make a little bit more sense as well. Next slide. All right, so this brings us to an overview of the ICHRA. So again, what is it? It's really an HRA account or health reimbursement account that will reimburse employees for their premiums. So the goal here is that they're going out, they're purchasing their own individual plan. It can be used with ACA exchange plans. It can be used with Medicare plans. The account is non-taxable, and it can be offered to a lot of different classes of employees. So there's some very specific regulations around that and how you can stratify that. One of the things, though, that's critical is it cannot be offered as an option alongside a group health insurance plan. So this is a standalone. It does satisfy the employer mandate portion of the Affordable Care Act as far as offering minimal coverage. And it does have a way that you can satisfy the Tier 2 component if your offering does meet affordability definitions. And again, we'll be getting into that a little bit later. It can be administered by spending account vendors. Many of you are likely have those today. But then there's also ICHRA-specific specialty vendors that have a much larger scope of what they're able to do for you and how they manage that. Now, again, I mentioned it may not make sense for everybody. So you'll see here on the slide, there's a number of different instances where something like this might make sense to explore. So for groups that are seeing maybe really unsustainable cost pressures, you have a lot of high cost claimants and you're really just struggling to manage that plan and increasing costs. We also see it in low margin industries where you're really struggling to provide ACA compliant coverage to maybe non-salaried employees, field employees, seasonal, that sort of thing. Smaller groups moving into an ACA AL employer definition, so over 50 full-time employees. And then depending upon where your group or your subgroups are located in various geographic areas, there may be more viable individual plan options there versus others. So that's also a factor. Groups with younger populations, toleration for disruption typically are good fits for this. And then again, I think the first step to this is really just having leadership that's willing to explore something that's different than a normal paradigm that you see with a traditional health insurance coverage. Next slide. So what's in it for you? So as an employee, there's really not a good one-size-fits-all situation here. This type of a strategy allows employees to choose the plan that's right for them. So there's really minimal employer involvement. You're not taking on the role of needing to choose what you think is best for your employees. They have the opportunity to go out and do that themselves. The other thing we always hear a lot of times that employers are looking for a way to offer something to their part-time employees, or maybe employees with variable hours where there's that 1 year period before they can necessarily qualify. So this solution can be really great for a number of employees and fits in those environments. As far as the employer, it really reduces that volatility of your health insurance plan coverage and limits your exposures, especially in a self-insured environment. And then also it might allow an employer that can't typically afford a traditional coverage to help them to attract or retain employees and still be able to offer something for those employees that wouldn't otherwise be able to get coverage through their employer. Next slide. All right, so will it save me money? I think that's the big question everybody has. And so the answer is yes, maybe, and probably. There's a few different things that it'll depend on. We'll walk you through some financial examples a little bit later, which I think will help maybe bring this full circle. But depending upon your enrollment level in this, what you set as your reimbursement amount, and then if there is any penalty exposure, depending upon those reimbursement amounts. As far as enrollment, initial trends are showing that ICHRA enrollment is about the same as group plan enrollment, so we're seeing employees are receptive to this. So assuming that there's a similar employee cost, this shouldn't be too much of a departure for your employees. And then when you are setting your contribution allowances, there's no maximum contribution limits. So there's a lot of here, even think. Again, I mentioned earlier, you can really vary the reimbursement levels by a number of different employee classes. So there's some different things that you'll need to focus on relative to the tenants, but worksite location and age are really important as well. And then there are some minimum employee class sizes that vary depending upon your size as a group on the whole. So you'll see those listed there as well. And then with that, while there is quite a bit of flexibility here, we still need to keep in mind that there are some legislative considerations as it relates to the Affordable Care Act, as I mentioned earlier. So I'll turn it over to Eric so he can discuss some of those.
Thank you, Lisa. So just with the ACA, and just for a little bit of background, the main rule I'm going to focus on here is what's called the employer mandate rules. And just to give you kind of a high level understanding of what that is and who has to deal with that, these rules apply to what are called the applicable large employers, which is someone who employs the equivalent of 50 or more full-time employees. That's determined by looking essentially at your average number of full-time employees and what are called full-time equivalent employees in the prior calendar year. You essentially take your full-time employee count and add up the hours of your non-full-time employees and create an equivalent number of full-time employees to look at whether you're over 50. And the results of being subject to these rules are that you can be potentially very costly if you don't meet these requirements. There are basically two components. So there's one that's called the A penalty, and this is in reference to a section of the federal tax code. And the A penalty applies if the employer does not offer minimum essential coverage to, in most cases, 95% or more of all full-time employees and their dependents. The consequences, and this is the big penalty, the consequences of violating this requirement is that there is a penalty currently. It's indexed each year. It's for 2021. It's $2,700 for each full-time employee less 30. So you can see as you get in, 100, 200, 300, 400 employees, et cetera, that can be a huge penalty because if you don't meet the threshold, it's applied essentially to every full-time employee. The second component is the B penalty, which is where if minimum essential coverage is offered or potentially not offered, but is not affordable and not minimum value, and that can lead to a penalty of, in 2021, currently $4,060. Now, the key with these is that neither penalty occurs unless at least one full-time employee goes on to one of the ACA exchanges and gets a premium tax credit. For larger companies, that's pretty common, and it's generally safe to assume or worth assuming that that's possibly going to happen and that there may be penalty exposure if you don't meet these requirements. The B penalty, importantly, though, it does not apply for every full-time employee. It only applies to a full-time employee who is not offered this affordable minimum value coverage and goes on the exchange with a subsidy. So although it's a higher amount for the penalty, at least annually, it's not usually as big of a penalty as triggering the A penalty because it's only on an employee-by-employee basis. So with that, the key is that when you look at these rules, for example, with affordability, when you're dealing with a regular employer coverage, you're just looking at what the employee is required to pay for the share of the lowest cost self-only coverage in the employer's plan. So that's easy. You have your own plan. You can look at that. It's much easier to figure out. With ICHRAs, this analysis becomes a lot more complex. So as I have in this slide, and I'll talk a little bit more about this in detail, at least the affordability aspect on the next slide, but an ICHRA satisfies the A penalty requirement. When you offer that, that's considered MEC, or minimum essential coverage. So if you, for example, offered an ICHRA to everybody, every employer, every full-time employee, that's going to meet the requirement. You're going to avoid that huge A penalty. So that's good. The B penalty requirement, as Lisa mentioned, this one gets a little trickier. The downside, I suppose, of an ICHRA is that it makes the administration a little bit more complex, because when you look at affordable, because they have individual coverage, you're looking at the premium for the exchange in the rating area the employee resides or potentially works. So for, based on when those are reported and having to go to potentially other sites and look up this information, it can make the analysis a lot trickier when you're trying to figure out whether something's affordable, which, as I know in this slide, is where you look at whether the employee's contribution, so what's not paid by the employer, and whether that's more than 9.83% of their household income. So if you want to take me to the next slide here, David. So, and Dave, if you want to click one more time, I think it'll, yes, thank you. So this is where it gets more complicated, as I mentioned, when you have to look at the premium for the exchange coverage. So the default rule for this is you're looking at the premium for the lowest cost silver plan in the exchange rating area where the employee resides. Now, those are usually published, I believe, around October of each year, which, as you're planning for open enrollment, is pretty tough. I mean, that doesn't give you really hardly any time to plan. Now, as I'll get into, there are additional safe harbors to use for this that make this a little easier. Otherwise, you'd be looking at, depending on how your company's set up, where your employees are located, you would be looking at potentially a lot of information, having to coordinate on an employee-by-employee basis. So with this regard, the IRS or Treasury have issued regulations that give you some additional guidance and make it a little easier to meet the affordability requirement, avoid the B penalty, without having to do quite as much work. These additional safe harbors, and with the caveat that these could potentially change. These were supposed to be final rules in January, but with the new president, it's common, and what happened here was these rules are put on a 60-day freeze, so they could potentially change. But what these rules essentially do is, rather than having to, and these are optional, rather than having to go look for each exchange and look up the applicable premiums for employees, you can do one thing, which is you can look at the work site, and you can use that to determine which exchange you need to look at for the premium. So potentially, where employees could be in multiple different rating areas in a state, you could just look on their work site. Now, the trick with remote workers is that if they don't work on site, or if you don't have an office to which they could be reasonably expected to be required to report, you still have to use their residence. I know that's in these times is possibly more likely. The other benefit, and these can be used together, is that they allow you to look at the January premium amount from last year if you're a calendar year plan, or the current year if you're a non-calendar year plan, so that then you have, at the time you're planning, for example, for open enrollment, you actually have the information available rather than having to try to, say, predict. So with these safe harbors, and as you get into ACA reporting, there are additional codes now for these. They can make it, I think, a lot more easy to deal with the affordability issue, at least administratively. The trade-off is that if you want the easier administrative approach, which is where you just pick essentially one rate for everybody in a class and you don't rate it by age, and to do that you would just pick the oldest person's rate, and then therefore it would be affordable for everybody younger as well. That's certainly more costly. Otherwise, you're looking essentially at a different affordable level of ICHRA amount for each age of employee. So that is sort of the trade-off, but essentially you're looking at kind of, I think, additional cost if you want to try something that's more simple to administer, or something that is less costly and more of a pain because you're essentially looking at a wide range of ICHRA amounts. So that's essentially, that's the crux of the ACA affordability issue. I mentioned that the plan must also be minimum value. Exchange plans are, so that requirement is met. And as a result, yeah, the thing to be aware of is, again, looking at who you offer your ICHRA to avoid that huge A penalty, and then whether it's a business decision and you want to look at whether you want to kind of potentially roll the dice, for example, with the B penalty or deal with the affordability rules. And if it's the latter, then there's potentially a more complex analysis. So from a compliance standpoint, I think that's just something that's good to be aware of. So I'm going to turn this over to, I believe James is now going to get into the remaining ICHRA items.
Yes, thank you, Eric, and hello, everyone. So I'm going to start off with a couple of analysis that we can do on behalf of our clients, and often is an analysis done by HRA administrators out in the market. But for a client of ours here that was spread out across several different states and had some of the issues that Lisa outlined in her introduction of why they had to look at alternative options, we put together this analysis for them based on at least 4 different divisions and 3 different states that they're in. And as we've kind of outlined, you need to start with looking at a plan option, and often what organizations will do is look at that silver option as their benchmark plan. And again, the plans will vary by each of the different locations and geographies. So we're looking at that on the front end, sharing that here in the top portion, and then really outlining the costs, which are, as everyone has explained, by age. And in this example, we're dividing it up between single and family. And so we're looking by enrollment, all of the different premiums in these different age categories, what the ICHRA costs would be, as well as what the contribution allowance would be provided. Again, there's a lot of flexibility in how this is done. For this particular group on the employee side, we did it with the same amount for each age category. But for the family, we varied it by age category. So again, as we go through this analysis, there'll be a lot of conversations, questions to really find out what makes sense. And we will also give our own recommendations as we go along. And so as we put this analysis together to figure out the contribution allowance strategy, we will then, if you can advance to the next slide, bring this together in an overall sample financial opportunity analysis. So this is really where everything comes together to state whether this might make sense versus, in this case, the fully insured option that you may currently have in place. So to orient you to the analysis here, it's really divided up by different enrollment levels. In this case, we really focused on just kind of the equal amount of employees enrolled in coverage would then enroll in ICHRA. And we are really, without getting into too much detail, looking at some very key areas. Obviously, we're going to look at the overall ICHRA costs. That includes both the contribution allowance amount, as well as a PEPM administration fee, because we have an HR administrator involved in this scenario. That doesn't always have to be the case. Employers can administer these programs on their own. I'll talk about that a little bit later, but in this case, they did partner. Then we're also going to look at how many employees may take advantage of the premium tax credits and thus trigger the ACA B penalty. This is also part of the analysis in what plans you choose to offer and what kind of opportunity there is for employees to look elsewhere and take advantage of the subsidies. But in this case, we outlined a 7 for the 100%, and then we're completing analysis of the taxes, comparing that to the fully insured net costs, and then coming up to show whether there's a savings or not. The only reason that there is examples being shown with coverage above the current enrollment is you may have individuals on the plan that don't take the traditional plan now that may be interested in taking the ICHRA once it's offered. As we explained earlier, we see it line up pretty closely to what the traditional insurance offering is. And then we have some other assumptions and inputs related to the taxation. On the next page, we really wanted to outline what that employee responsibility and experience is with the ICHRA. And so Lisa alluded to the fact that they're really choosing and purchasing the healthcare on the individual market. And that gives a lot of flexibility because obviously everyone has unique needs in the market based on age, family, and conditions and so forth. So this gives them that flexibility to do that. And again, if there's an HR administrator involved, they're really going to help with that, that experience. The individual health insurance needs to be purchased and then in place before any of those ICHRA allowances and reimbursements can be provided. And the employee has that responsibility to show that proof of coverage to the employer, if they're responsible, or the HR administrator on an annual basis. Then, as we had mentioned, the employee is responsible for paying that full health insurance premium, and then will get reimbursed up to the monthly contribution allowance. Now, depending on what type of coverage that they choose, they may not use the full contribution allowance. And in those scenarios, they can, if the employer decides to offer it this way, they can use those dollars for additional expenses that in a sense would naturally be covered under the IRS code for health reimbursement accounts, but obviously needing to also provide the proof of those eligible expenses. On the next page. Best practices for administration. This is more complex. There is the opportunity, if an employer moves this direction, that there's more responsibility on them. We see many employers that do partner with HRA administrators, but you do have a choice. And some of the areas that fall onto the employer are things that you naturally think of with a medical insurance plan, written plan documents and SPDs, making sure that that the compliance is met with the HRA and group health plan requirements, ERISA, and so forth. The claim processing and reimbursement administration, so you are then handling all the different reimbursements that are coming through from the employees. There's, of course, the record keeping, as we talked about, with approved health coverage, any HIPAA, privacy, security compliance that comes along as you've been used to probably in the past. There is some level of COBRA administration. Again, a third party can be used potentially for that, and then tax reporting. But on the next page, kind of the ideal situation is to partner with a HR administrator and technology group. In this situation, they can really take much of that administration off the plate, create those documents, do a lot of the collection, processing of those reimbursement requests, take some of the liability, obviously, off of the employer that is then put on them, really manage the process almost from A to Z, and really make sure that your employees are having as good of an experience as possible, really customizing that experience on the health insurance market so that they have help in this very new environment that they're in to find what's best, the best options for them, making that reimbursement process as simple as possible. There's some things that can be done on the timing that then help them on how long that they have to fund that premium differential. And then just really making things easily accessible and obviously having customer support at all times. So, and in conclusion of this section, we just wanted to kind of review the ICHRA considerations. So really those advantages and potential disadvantages, as Lisa laid out from the very beginning, this may not be an option for all organizations. There's a lot of considerations that go into this, and we see organizations having a very tough medical cost situation at least evaluate this option because of the cost savings that are involved. The thought that there's no business size restriction makes this a very appealing option. Of course, the employer and employee tax savings that we've outlined, predictable year-over-year budgeting, just really having that defined contribution strategy that you can apply and in a flexible way is something that you may not have had in the past with a traditional plan. And for the employees, again, to have that opportunity to find plans that fit their needs versus a one-size-fits-all scenario. This can also be provided as Medicare solution out there. And as I ended the section, really having a lot of the administration off of the employer and onto an administrator or vendor. But with all that said, this is a very unfamiliar, new type of option out there that's been in the market for about a year and a half. There's nothing to take away from the fact that the individual markets are complex and there is premium volatility, although we are seeing some better progress there and support now from the government. The employees front loading that premium, there's a lot of discussion there and what's comfortable for your population. Lack of traditional coverage is, a change like this can be viewed negatively, but there's a lot of communication that can go on in order to make that transition much easier. And then really, as we said, if you decide to go down this path without an administrator, the complexity of keeping up with the documentation, the regulations, the reimbursement can be a lot to handle. So I think that concludes the ICHRA section, and I will now hand it off to the esteemed Kent Horseman to talk about MEC plans.
Great, thanks, James. Kent Horseman. I've been with Lockton for 9 years, and I handle a lot of our ACA risk analysis with several of our clients. And one thing that we wanted to talk about today is just what are the options of a minimum essential plan, and how can that relate to what used to be known as a mini-med plan? And are those options available either alongside a traditional plan or as a standalone type of option? And in different cases, we may find different values within our analysis. But I wanted to start out with just what a MEC plan is and how it can be provided to employees. Like I said today, MEC plans can be built as a mini-med plan and include some coverages that are essential to the definition, and that's preventive care, being paid at 100%, meeting that tier 1 level of responsibility in the ACA. But it's also recently, we've seen plans that really encourage or bring coverage in for things like urgent care, physician's visits. Telemedicine is obviously a big thing in today's world. And most importantly, pharmacy. A lot of people that choose a minimum plan really choose because they just have routine medications, maintenance meds that they take and really want covered without deductibles. We can also include some type of limited coverages. You can't put, as complex of a coverage around some of the major events like hospitalizations, surgeries, major diagnostics. But we can put in some type of limited coverage for those scopes. And the most important thing is MEC plans are always a fraction of a cost of a traditional medical plan, which is what makes them somewhat attractive to employers that are struggling with some of the runaway medical trends. Next slide. So I wanted to give you a construction of a MEC plan. What do modern day MEC plans look like? And of course, as we mentioned, the preventive care is required to begin the plan at 100% of cost for in-network services. But then there's options. You can kind of build your own plan in a lot of ways today, where you can include that acute care coverage. I might be buying a plan. I might be interested in a limited plan like this because I just don't use medical that often. But when I do, it's usually an emergency or it's an unexpected event. So building in things like a $10 copay for primary care or a $25 copay for urgent care become very, very popular programs. A 3-tiered drug plan is probably the most utilized component of a minimum plan. And building in, say, cost structures like a $10, $20, $40 copay type of arrangement for pharmacy. It has been a very, very popular component of these type of things. Telemedicine, of course, has been really a major growth sector in the medical world. And of course, with a minimum plan, telemedicine becomes even much more important. Giving people 24-hour access to care. And then, of course, that fee-for-services component that I mentioned earlier, where we can build in some type of limited scope coverage for things like a hospitalization or a confinement or a surgery, those kind of things, where it gives them some kind of dollars to negotiate with, I guess, for the cost of those services. Next slide, if you would. So who does this solution serve? So when we take a look at the analysis, generally speaking, we're looking at employers that have maybe lower wage employees, and the cost of providing medical insurance relative to the cost of labor can be very high. We've seen, 20-25% sometimes is when you're paying somebody at $8, $10, $12 an hour type position, the cost of offering insurance can be a significant percentage of the total labor cost. High turnover industries, these are places where maybe benefits haven't really stabilized the population. A big factor is low medical participation. As we're seeing costs go up and deductibles go up, we're also seeing some folks not participating at a high clip, and you're seeing large populations of non-participants. Of course, your variable hour employee, where you're tracking hours, this is a nice way to add an ACA compliant plan that shields you from any type of ACA risk. There's a lot of consulting that goes into that strategy. And certainly with employers that see an increasing medical trend, James and I have recently worked with a couple companies that just had some runaway medical costs that we've engaged with and have become very close to, given the nature of how we consult with these mini meds. So I've mentioned a few of these here on the left-hand side: your staffing, your hospitality, your restaurant groups, your service workers, places with seasonal labor, places with low group medical populations. These are places where we really should do an analysis and look at what options are available for that group. It's not always the right answer to offer something like this, but often there are a lot of dollars to be saved and really employees to be served. Next slide. So I wanted to give you just a general sense. I don't want to spend too much time on this slide, but kind of give you just a breakdown of what can be done and the cost factor. I really want to point out the costs at the bottom of the page. And as you can see, these are a fraction of traditional medical costs. James' slide earlier had, your medical costs, typically, that $500 a range per month for an employee only. Family coverage is at $1,300 to $1,700 a month is kind of a traditional rate. These are numbers that some people, especially at that lower wage threshold, can afford. And with an employer contribution, you can imagine, these are gross costs. So an employer contribution of $50 goes a long way to the affordability of getting something, especially if that something has a no deductible access to acute care. Next slide. So I want to turn it over to Eric here to talk about the ACA in relation to MEC.
Thank you, Kent. So yeah, I'll cover a few compliance issues related to these MEC plans in these couple slides here. Just to start again with the, as I mentioned, I talked about this in the ICHRA context. When you're dealing with the ACA's employer shared responsibility rules for large employers, there are some considerations for these MEC plans. The first is when I refer again to this large A penalty, which is potentially up to $2,700 annually times each full-time employee. To avoid this big penalty, as the name suggests, a MEC plan is going to accomplish that. This requirement deals with just offering minimum essential coverage to full-time employees and their dependents. It doesn't look at affordability or anything else. So for this reason, a MEC plan for this reason can certainly be a very useful tool. For example, employers, as Kent mentioned, within certain industries or with certain employee groups where as has been mentioned, it can be very expensive to provide larger scope, affordable health coverage. A MEC plan can be something that's offered instead of that to avoid this potentially huge ACA penalty. The downside, and this often becomes a business decision about risk and possible costs, is with the B penalty, that's where a penalty for each full-time employee who's not offered affordable and minimum value coverage, who actually goes on an ACA exchange and gets a subsidy. That penalty, which again is usually often a lot less than what you'd be exposed in a penalty, because not every employee who declines your coverage is going to go on an ACA exchange or even necessarily qualify for a subsidy. But in cases where they do, there's exposure when you're offering just these traditional MEC plans. The reason being is that regardless of whether they're quote affordable, at least the traditional sort of MEC mini-med design is not going to be minimum value as well, which is a standard that looks essentially, when you look at as an actuarial standpoint, whether the plan is going to cover 60% of expected medical claims. So with a plan with this low of scope, and again, you could possibly stack on enough services to meet the minimum value requirement, but usually when what you're looking at in this context, that's not going to happen. So as a result, there is some potential B penalty exposure. Now, some companies look at this, they try to project what they think their B penalties would be, and they maybe compare it to what it would cost them to provide broader, affordable health coverage to employees, and they decide that it's a legitimate business decision. Because in contrast to, say, ERISA or other laws where there are penalties for quote violations, these ACA employer rules are really just taxes. They're not necessarily quote like violating the law if you choose, for example, not to offer coverage. So again, for this MEC plan and with regard to these ACA B penalties, sometimes it's just a business decision about risk and expenses. Next slide, please. Just a few other additional compliance considerations. Obviously, there's a lot of rules that any employer-sponsored plan has to deal with. Just to mention a few other ones in the sort of the MEC only or the MEC context. Starting with sort of benefit mandates. And I note that at the federal level for employer plans, there are very few required things that you have to cover. For example, preventive care is one of them. But because of how these laws work, a law called ERISA preempts many state laws. These MEC-only plans are not driven by too many required coverage mandates, at least when they're self-funded. When they are fully insured, you're potentially dealing with additional things you may have to cover under state insurance law. That's another consideration. I've often seen these self-funded for other reasons as well, including the employee premium. Sometimes, for example, I mentioned you could offer a MEC-only plan where the employee pays everything and still avoid the larger ACA penalty. Well, you may not necessarily be able to find an insurer that's going to offer that kind of product and allow you not to kick in anything for, I think, among other things, what they call adverse selection issues. Just one other thing I'll note with benefit coverage mandates, and this is probably pretty limited in the MEC-only plan context, but there is legislation recently, the Consolidated Appropriations Act 2021, that was recently enacted and has some provisions that are effective immediately and some that essentially take effect at the start of next year. And there's way too many provisions discussed in this in general about that could impact employer plans. But I just note that MEC plans may have to deal with some of these requirements. Now, again, I think money will be more applicable to broader scope employer plans. But for example, these rules that would take effect the start of next year include additional requirements regarding coverage of emergency care, things like air ambulance for non-network benefits. So if you're starting to add in emergency coverage and potentially non-network emergency coverage, those are additional design constraints that you may have to deal with. Now, it's not an obstacle to offering one of these MEC-only plans. It's just something to be aware of. The other are the tax non-discrimination rules. And when I mentioned these, there's two different ones largely that you're dealing with. One is that if you offer a self-funded medical plan, you deal with the rules under Section 105H. The other is cafeteria plans, which relate to pre-tax contributions to medical or dental vision coverage, et cetera. And the consequences of potentially violating these rules, which occurs if you favor what are called highly compensated employees impermissibly with eligibility or benefits. So, for example, offering richer coverage to executives and nobody else possibly could violate these rules. The concern is that this might come up depending on how you structure your overall benefits offerings. If, for example, you're only offering certain employees this MEC plan and you're offering richer benefits to others. Now, there are ways to potentially make this work, but it's something that I think you need to look at and you want to look at as you just look at all of your overall benefits offerings, because to run afoul of these rules could result in the highly compensated employees losing their pretty generous tax exclusion for their contributions and benefits under these plans. Now, there are rules. There's ways you can tinker with testing. You can break your different benefits apart and test them each separately and potentially pass. For example, testing the MEC plan separately from your other plans. So in many cases, you may be able to work around these rules, but I just mention these because I think it's something that you certainly want to be aware of when you're looking at offering these MEC plans and then offering potentially other benefits to other employees. So those are just some, I think, key compliance issues to be aware of, or just to at least be looking at when you're considering or when you're implementing a MEC plan. And on that, I'll turn it, I think, back to Kent here to cover some additional items on this.
Yeah, sounds good. So really we're looking at what are some of the common evaluation questions that we look for from an employer. And I don't want to go through each one of these, but these are great, I guess, catalysts to explore what the design could be and do some analysis on whether or not a group is right for a creative design like this. And of course, what are those costs of ACA compliance? What are some of my risks for that B penalty? Are my employees getting, what they're really wanting out of this benefit plan? Could we be redesigning things to meet the needs of the majority of our employees? And so really, these are some of the things that we would look forward to question with our clients and help, make a dynamic discussion around whether or not maybe we could lower the cost of overall benefit spend by redesigning the program and making it maybe more relevant to that particular employee group. Next slide. I really just wanted to hit on, a few of our examples. I de-identified this data, but this kind of gives you an idea of the impact that an ACA risk strategy can provide a client. So anyone who's in one of those industries that I referred to in the previous slides, these are pretty consistent analysis results when it comes to doing some type of a MEC inclusion. Now, whether that be a MEC exclusively type of option, or maybe a MEC alongside a high deductible health plan. There are a lot of ways to approach this and meet the needs of the employees. And it really depends on the appetite of the employer to take risk. But in most of these evaluations, the results of moving toward a MEC strategy, either exclusively or alongside a medical plan, can really drive costs down. And we're seeing where the green box here, or green rectangles, I guess, are really representing the savings of any one of these three clients. The last slide that I want to take a look at here.
Sorry, Kent, just as a quick note, we are notorious in our world for using acronyms. So I just want to make sure that everybody understands that ER is not actually emergency room, that is employer spend.
Oh, yes. Good call, Lisa. Thank you. Last slide for me, really just wanted to give you an idea. These are two different clients that we worked with, very different. Client one was a janitorial company. And the reason I separated these two out is that the client one offers a MEC plan alongside a major medical plan, has done so since the advent of the ACA, went into effect in 2014. And I put this in because in their particular industry, that ACA rule from the very beginning caused significant labor cost challenges for groups like this. These are populations that traditionally did not offer a medical plan prior to the ACA. And the introduction of ACA represented, in their case, several $1 million of liability to offer a medical plan. And so for the past 7 years, we've been working with this particular group offering a MEC plan. And that MEC plan has evolved probably 4 times over since that first introduction to try to meet those employee needs with the pharmacy, with the urgent care components, helping people get to the care that they need in a population that really only participates in benefits at about 15% clip. So it's a great way to offer a program and save dollars while sheltering themselves from any ACA penalties. So that was a good example of client one. Client two, I put in to this example as well. This is a recent implementation. We just actually implemented this MEC plan for 1/1/2021, where they had a large group of field workers who only 22% of them took the medical plan. And the reason for that is the skyrocketing cost. The medical trend was becoming a significant problem. The adverse selection was a problem. And only 22% of the population taking a plan really tells them that the benefit plan wasn't attracting and retaining people. And so we basically did a revamp and offered a MEC plan to this population, where the population could go out to the exchanges, get a subsidy, and the employer was more than happy to take on the B penalty, because the B penalty represented almost half of what their cost would be if they participated in their company plan. So it was actually a savings to take on the B penalty in their case, while at the same time they saved several $1 million per year switching over to a MEC strategy, while still feeling like their employees could get the care and the access to plans that they needed by putting out a mini-med type option that was going to meet some of their needs, while putting out a lot of communication and a lot of concierge help, so that if people did need the traditional medical plan, they could go out to the ACA exchanges, buy subsidized coverage, and that employer would then happily take on the B penalty, because the cost of the B penalty represented a much lower cost, again, from their original structure. So there's so many different dynamics of how we can work with companies to analyze where their risks lie and how they can redesign the complex components of their eligibility to put them in the best financial position possible. Next slide. And James, is this you or Lisa? I'm sorry.
Ken, I think that it's all about the MEC plan, the advantages and disadvantages. It's just incorrectly titled. Yep, exactly.
Thank you. Thank you. Oh yes, the advantages of the employee. You've got different populations, different people utilize benefits in different ways. So one size doesn't fit all. In my previous example, again, when only 22% of the staff is taking the plan, it's obviously not meeting the needs of the larger population. Can you obtain coverage needed at that affordable price? We saw the gross cost of a MEC plan. You can offer somebody a plan for, say, $60 to $80 a month with no deductible for immediate health care. That's going to meet the needs of a lot of people, especially in the lower wage populations. Disadvantages, certainly you've got, major health events can strike, and how do people assess that? Obviously, people with higher risks, would they be on a more traditional plan through the exchange? Would they have access to other care? We do like to put a lot of communication behind these strategies and concierge services so that they can access care. And then, obviously meeting that individual mandate in a few states. It's not a big issue, especially in the Midwest where I reside, but obviously some of the East Coast states can have some challenges with the individual mandate. Certainly at the employer level, we talked about the volatility of health plan coverage, and this type of strategy can limit their exposure to some of the risks that they're taking on. And we saw some of the savings advantages, and I think that's really the biggest reason to do that. But certainly if the traditional coverages is not attracting and retaining employees at the desired rate, maybe a different approach is reasonable. And that's where we come in to consult, make sure that people understand what all their options are, what the risks of those options are, and then implement a strategy to provide the right benefits for the right workforce. Next slide.
Okay.
So here we're going to open it up to discussions and questions. So Eric and David, if you'd like to take this, that'd be great.
Sure. So let's go ahead and get started with a couple questions here. Thank you, folks, for your patience as we got through the slides. And Eric, this question is for you. Can you offer a MEC plan to part-time employees while still offering a regular self-insured plan to full-time employees? Is there any compliance-related issues or extreme costs to doing so?
So can you do that? As a compliance matter, yes, I think you could. I'm not aware of anything in ERISA or another law that would outright prohibit that. From an ACA employer mandate standpoint, part-time employees are not going to trigger ACA penalties. So there's potentially no exposure there in that regard. Now, note that you need to be a little careful on who you can treat as part-time for this purpose, because the ACA rules are potentially a lot more complicated in making that determination than what you might use just for general business purposes. I also note that I mentioned tax non-discrimination rules earlier. As a general matter, you can exclude part-time employees from that analysis, preventing the exposure in that regard. So yes, I think that is, and I have seen that design used, and it's certainly, I think, something that you can do from a compliance standpoint.
Okay, great. And to the person that asked that question, if you would like to discuss that in more depth, you're welcome to reach out to HBL, and we can get you in touch with someone on the team who can walk through your options. We have another question here. I'm going to let James, if you could lead off on the answer here, and then Eric, if you would like to piggyback on James' answer, let's do that. If you already offer and also contribute to an HSA, how does that impact having the ICHRA as an employer?
Actually, David, I think I was going to have Eric address this one.
Oh, great.
Sure.
No worries. Yeah, Eric, go for it.
Happy to take it. So just from a design standpoint in regard to the requirements for both the HSA rules and the ICHRA rules, unfortunately, you're not going to be able to offer both. Under the HSA rules, for someone to be eligible to have HSA contributions, they have to be enrolled in a high deductible health plan and not other impermissible coverage. An HRA is going to be other coverage that's going to cause someone to lose HSA eligibility. So that's the HSA part. From the ICHRA part, we mentioned there's a lot of rules that apply to these. We talked about contribution amounts. Another rule relates to what you can offer to employees. And as a general matter, within each class, we mentioned there are 11 classes of employee groups. You can't offer both an ICHRA and a major medical employer plan. So when I mentioned for the HSA requirement and being enrolled in a high deductible health plan, that's not something they're going to be able to have with an ICHRA. So it's essentially a choice between the two. Now, somebody who already has amounts in their HSA, they don't lose that because they're in an ICHRA. They can still use that for expenses. They just can't receive additional contributions while they have ICHRA coverage. So that's, I think, from a compliance standpoint at least, the limits on offering an ICHRA with an HSA.
Okay, great. Thank you, Eric. On behalf of Lockton Companies, on behalf of Hall Benefits Law, I'd just like to take a second to say thank you for all of you who have attended. You will be receiving a follow-up email from both HBL and from Lockton thanking you for your attendance. I would like to remind you there is a copy of the slides in the handout section of your GoToWebinar control panel, as well as a couple of handouts from Hall Benefits Law regarding our services. If you've got any questions for anyone, please reach out directly to Lisa Metcalf at Lockton, and her email address and direct line are found on the slide that you're looking at right now, or you can reach out directly to me, dhall@hallbenefitslaw.com, and that is my direct line. I hope to hear from you. And if you've got any questions for the panelists, again, please reach out to Lisa or David directly. Thank you, Lockton, for your presentation today. Thank you, Eric, for your time. I know we've got a lot of clients keeping you busy, and so we're gonna let you guys go. Thank you again, and we hope to see you for our next webinar.
Thank you, David.
Thank you, everyone.